Thank you very much. I would really like to thank the organizers for allowing me to participate in this wonderful meeting. It looks like a great program over the next few days. And I'm particularly thankful for the organizers that they asked me to specifically talk about this topic, because I think this is an important topic that is neglected, and it's a black box for many people. People have difficulty understanding what electrophysiology is about. And what I'd like to do over the next few minutes is give you a solid understanding of at least full field ERG and how it can help us. So there are two important points I'd like you to remember, and I'll start with these 2 points, because if you remember nothing else, remember these 2 points. One is that full field ERG is time consuming to perform, it requires skill to perform, and it needs careful interpretation in the context of a clinical exam. It's not like doing a fundus photo. It's not a hobby. You have to have some skill, you have to have some understanding, you have to have a proper setup to do it. And the second point is the most important point of this whole talk, and that is a good ophthalmologist is better than excellent electrophysiology. Electrophysiology doesn't give you a diagnosis. You have to do an exam, you have to have a specific question, and electrophysiology will answer that question. It's meaningless on its own, without a good clinical exam, without a good interpretation. So what is electrophysiology about? Is this gone? Okay, it's gone on the screen over there. Anyway, the retina, electrophysiology is a measure of the global electrical activity of the retina. It's a measure of global electrical retinal function. When we do electrophysiology, we put some electrodes on the eye, we send some standard light into the eye under some standard conditions. It sets up a circuit, and we measure the electrical activity of the retina on a global scale under standard parameters. Electrophysiology allows us to dissect the retina on a global level. It dissects inner from outer retina, and it dissects rods from cones. So it gives us an idea of global retinal function. It is important to understand what standard electrophysiology does not give us. It doesn't tell us anything about ganglion cells. So someone with an optic neuropathy will have normal full field electrophysiology. And the other thing that electrophysiology doesn't tell us anything about is foveal function. So it tells us nothing about visual acuity. Very often a patient with a panretinal dysfunction also has a dysfunctional fovea and low visual acuity, but someone can have 20/20 vision and a non-recordable ERG because the fovea is a very small electrical contribution to the retina, and full field ERG is measuring the retina on a global scale. I'm not going to go through the different waveforms. I just want you to understand the concepts. And now let's go straight into indications for ERG. And I'm going to go through 4 in the time allocated to me. The first indication is to assess if pigmentary or fibrotic changes in the retina are associated with global retinal dysfunction. The only way to do that is by doing a full field ERG. So here's a 4-year-old boy who comes in with accommodative esotropia, and he also has these funny-looking fibrotic lesions on the retina. What is that all about? Does that have something to do with global retinal dysfunction? The only way to know that is by doing a full field ERG. And when we do an ERG on this child, I'm not going to go through the details, just take my word for it, and we can talk about it later if you'd like. It has a signature that is specific for a genetic diagnosis, the enhanced S-cone syndrome. We just made a genetic diagnosis without doing any genetic testing. The ERG is that specific for some conditions. And enhanced S-cone syndrome, Goldmann-Favre syndrome, is one of the few conditions that has a pathognomonic ERG. Here's a young woman who came in for an eye exam, just for a routine eye exam, and had these funny pigmentary changes. She was actually asymptomatic. Is this part of retinitis pigmentosa? Is this a retinal dysfunction? Again, how do we know? We do an ERG, and when we do a full field ERG, she has rod cone dysfunction. She has undiagnosed retinitis pigmentosa. The ERG allows us to make that diagnosis. The second full field ERG indication is maculopathy. Anybody who comes in with a maculopathy, you don't know if it's only isolated to the macula or if it's global retinal dysfunction. The only way to know that is by doing a full field ERG. And sometimes the pattern of the ERG can actually give you a specific genetic diagnosis. So here's a 12-year-old boy with decreasing vision. He comes in, he has a maculopathy, only the right eye is shown, both eyes are the same. We do an ERG to understand what's going on, and he's got a cone rod dystrophy. The only way we can make that diagnosis is by ERG. Here's another 12-year-old boy with decreasing vision. He also has a maculopathy. We do an ERG on him, and it is one of these ERGs that has a characteristic signature. This patient has cone rod dystrophy with supernormal rod response. This is a specific genetic diagnosis. Again, we've made a genetic diagnosis without doing any genetic testing, just by doing an ERG. The third indication I'd like to share with you is unexplained poor vision or nystagmus, particularly in infants, or poor night vision. This is a classic indication for ERG testing. So a child comes in with poor vision, is not seeing well, everything looks normal. Usually that is panretinal dysfunction, and we can sort that out and get specific diagnoses by doing ERG. I'm not going to go through the different diagnoses, just suffice it to say there are 4 classic ERG diagnoses for the apparently blind infant with a normal fundus appearance. The other indication, again, is poor night vision. Here's a girl who was referred for nystagmus. She has esotropia myopia, and the mother insists she has poor vision at night. She's seen some retina specialists. Everyone says the retina is normal, and the retina does look normal. Multimodal imaging is normal, other than myopic changes, but her vision is a little bit down. The mother insists she has poor night vision. The only way to sort this out, the only way to know what's going on, is an ERG. Again, the multimodal imaging is all normal. ERG, though, has a classic signature for congenital stationary night blindness, and the only way to make that diagnosis is by doing an ERG. No other imaging, no other test is going to give you that diagnosis. I'll tell you, there are many patients with this diagnosis who are walking around undiagnosed because no one ever did an ERG. They only had multimodal imaging. No one took their complaints seriously. The final indication I'd like to share with you, I'm not going to give you any examples, but I just want to mention it, and that's to follow panretinal function worsening or improvement after an intervention. For example, gene therapy or following the toxic effect of a medication. This is not really a good indication for full field ERG. Why? Because full field ERG is a measure of global retinal dysfunction. It's not really sensitive to small changes, but I put this in for completeness. So to summarize, I've gone through indications for full field ERG. It is something that is needed if you're going to practice ophthalmology completely and treat all patients. But I want to stress that it's not something to do casually. It's not like doing a fundus photo, and it's completely meaningless without a good clinical exam. An ophthalmologist, good ophthalmologist, is better than excellent quality electrophysiology. Thank you.